Testing. Oh, testing. 1, 2, 3. May 19, 2015. Ways and Means meeting. Good.
Have to hit the talk button and speak into it, but when you're done,
Welcome to today's hearing on improving competition within the important Medicare program. This is the first in a series of hearings this summer and fall to identify solutions to saving Medicare for the long term. Today we're going to explore how much competition exists in Medicare, its impact, its benefits, and savings for Medicare patients, as well as the potential for improving Medicare access and choices through more competition. We're also going to hear about two ideas to make Medicare more responsive to seniors' needs while also driving down costs and expanding access. Competition is a good thing. It drives down costs and increases access while improving quality. Most importantly, it empowers consumers. Competition and the choices it offers is how we discover information on prices and quality. And it gives families the power to decide what they want to buy and how to stretch their dollars further. Competition is a critical component of virtually every sector in our economy, save one, Medicare. More often than not, Medicare stifles competition and choices. Through legislative action and agency enforcement, Medicare sets prices and sets the standards by which it determines quality. Rather than empowering consumers, the Medicare program limits choices. This system is set up so that providers are more likely to fight rulemaking decisions handed down from government agencies than they are to compete with each other to offer better services to Medicare patients. The Medicare fee-for-service program is a perfect example. For this fiscal year, Medicare is projected to pay $375 billion for Part A and Part B services, that is, doctor and hospital services. For the vast majority of that spending, the Centers for Medicare and Medicaid Services is directly responsible for setting, implementing, and managing these payments. In other words, a massive bureaucracy picks winners and losers among countless healthcare providers. Competition and choice and the preferences of Medicare seniors play little role in the administration of all that spending. And it shows the program, unfortunately, is going insolvent. By contrast, competition and choices for seniors play a proven critical role in two successful programs, the Medicare Advantage program and Medicare Part D, which provides prescription drugs. In these two extremely popular programs, Medicare seniors are the ones in control, not the government. Plans compete fiercely for their health care business, offering services and benefits to fit the needs of Medicare patients, not Washington. And if consumers are unhappy with their service, they can say no thanks and change their plan to one that meets their needs. It's that simple, and it works. Right now, seniors have access to more than 3,600 Medicare Advantage plans tailored to meet their specific needs. Competition is robust, and not surprisingly, patient satisfaction is high. The same is true with the Part D prescription drug program, which is one of the few government health programs that actually come in under budget projections, and whose average base monthly premiums are as low today at $33 as when the program began in 2006 at $32. For Medicare prescription plans, seniors have dozens of choices in each state and can pick a plan that works for them. Studies show this very fact has led to a decrease in their out-of-pocket costs, which is great news for seniors. Competition is proven to work in Medicare Advantage, and it works in the Part D prescription drug program. So how can it work in the larger Medicare fee-for-service system? Today we'll look at two proposals to do just that. The first is expanding seniors' access to local physician-owned hospitals. This is an issue Mr. Johnson of Texas has been working on for quite some time. Physician-owned hospitals are full-service community hospitals that serve both rural and urban communities. They specialize in providing essential health services in areas that are considered underserved. But since 2005, these hospitals have been prevented from growing to meet the needs of their communities. As a consequence, there are just over 230 of these kinds of hospitals in operation around the country compared to 3,400 national acute care hospitals. The questions before us include, should seniors continue to be blocked from access to these high-performing hospitals? What are the impacts, pro and con, of this discrimination against one model of acute care? And is the current ban based on quality of service or desire to restrain competition? At this point, a decade into the temporary moratorium, it's the right time to have a thoughtful discussion on this issue. The second idea seeks to improve the way Medicare currently administers the durable medical equipment benefit. Dr. Tom Price of Georgia has spent a significant amount of time looking at this issue, as well as other members of this panel and the Ways and Means Committee. He's been working on a reform that would inject a more market-based approach to help address some of the more serious concerns members of Congress from both parties have all heard about from our constituents. These two proposals have the potential for improving competition and the benefits within Medicare. But ultimately, Congress needs to examine how we administer the Medicare program overall. The current program is critical but unsustainable. Everyone from the program's own actuaries to nonpartisan scorekeepers like the Congressional Budget Office to outside watchdog groups have worried about this and warned us about this growing problem. Members of both parties in Congress have a responsibility to save Medicare for the long term, to improve and protect Medicare for today's seniors and for future generations. We recently took the first important step by solving the way Medicare pays its doctors. For the second step, we must turn immediately to exploring how we improve the way Medicare pays its other healthcare providers, from the testing and evaluation leading into the hospital to pay inpatient and outpatient care and post-acute care after leaving a hospital. The Health Subcommittee will continue to hold hearings on this topic over the course of this year and develop reforms that will put Medicare on a sustainable path. So to help us get started, I'd like to welcome today's witnesses, Joe Antos from the American Enterprise Institute, Joe Minisali, president of Methodist McKinney Hospital in Texas, Robert Steedley, the president of Barnes Healthcare Services in Georgia, and Richard Umdenstock, president and CEO of the American Hospital Association. And before I recognize the ranking member, Dr. McDermott, for the purposes of an opening statement, I ask unanimous consent that all members' written statements be included in the record. Without objection, so ordered. I now recognize Dr. McDermott for his opening statement.
Thank you, Mr. Chairman. We're here today to talk about the second part of healthcare reform, that is control of costs. Access under the Affordable Care Act is rising clearly. More people have access to healthcare, supposedly. So the question then is about how do you get control of costs? And we're talking today about improving competition in Medicare. Now, I can't help but wonder, having sat here for a number of years, what this hearing is really going to accomplish. Because if this hearing were about competition, we would look carefully at how to drive down prices and get a handle on healthcare costs. That would mean reducing waste and overpayment to industries that are profiting at the expense of the American public. The more the American medical industrial complex is into the government pocket, the more it becomes our issue here. Unfortunately, the proposals we will hear this morning won't control costs. Instead, they are designed to appease the very interests that benefit from the waste in the system and contribute to higher healthcare spending. A hearing like this would make us ask ourselves, are we serious about controlling costs, or would we rather just talk about it? We're going to discuss ways to revise Medicare's competitive bidding program for durable medical equipment. Specifically, we'll hear a proposal that would put a halt to the existing program, reduce competition, and ultimately increase costs for Medicare and beneficiaries. The real irony of this hearing is, because I remember when it was Republicans who were the champions of competitive bidding. I've been on this committee long enough and listened to all this, and the problem of healthcare costs in devices has been there. It was a Republican Congress that first introduced the concept to Medicare as a demonstration project in the Balanced Budget Amendment Act of 1997. And it was a Republican Congress that expanded the program in 2003 as a part of the prescription drug legislation. Now, despite some hiccups along the way, the programs have had a remarkable success, or at least a measurable success. The first round of competitive bidding saved over $580 million in 2 years, and HHS projects that over 10 years, we will save nearly $43 billion. Of course, we should continue to carefully oversee the implementation of competitive bidding, but proposals like the one that is before us today to delay or undermine signals to the American people that Congress is more concerned about appeasing an industry than it is about controlling costs. We are also going to discuss the moratorium on new and expanded physician-owned hospitals. For many years, specialty hospitals enjoyed a loophole in the Stark Act that allowed doctors to make referrals to hospitals in which they had an ownership interest. As long as their ownership interest was in the whole hospital rather than a subdivision of it, they couldn't have just one department, physicians could make referrals that otherwise would have been illegal. The result was a rapid growth in physician-owned hospitals, which skewed the market in troubling ways. Nonpartisan experts at MedPAC, GAO, the Office of the Inspector General, for years have expressed serious concerns that these hospitals increase utilization of services and drive up healthcare costs. Now, closing this loophole is a cost-saving measure that has always had bipartisan support. We passed temporary moratoriums during the Republican-controlled Congresses, and we made it permanent as a part of the Affordable Care Act. This reform will save the American people $500 million, according to the CBO. There is simply no good reason to reverse course and undo this progress. It will make the industry happy, but it will bring needless waste back into the healthcare system and ultimately harm the hardworking families of this country who are paying for this system. Getting serious about controlling costs is more important now than ever. The Affordable Care Act continues to expand access. We got more and more people covered. Everybody's clapping their hands and popping the corks on champagne bottles about how many more people. When all is said and done, more than 30 million additional people have been brought into the system. And as this happens, the healthcare system is rapidly changing. Medicine is transforming from a profession into a business. Market power is consolidating into fewer and fewer hands as hospitals merge and swallow up independent doctors' practices. This raises a number of questions about competition, costs, and patient care that we need to answer. And until we take a careful look at what this trend means, we are sending a message to the American people that appeasing wasteful industry actors is more important than controlling costs. I sent a letter to the chairman earlier about my concerns about consolidating hospitals and having less and less competition in various parts of the country, and I would, ask unanimous consent to have that put into the record. And I yield back the balance of my time.
Thank you. Mr. Antos, welcome today, and you're recognized for 5 minutes. Please go ahead.
Thank you, Chairman Brady and Ranking Member McDermott and members of the committee. Competition is central to obtaining good value for the dollars spent by beneficiaries and taxpayers in the Medicare program. Congress must avoid the temptation to smother competitive markets in Medicare through overregulation. Private plans must follow rules, private providers must follow rules designed to protect consumers and ensure access to all necessary health services covered by the program. But the regulations should not be drawn so narrowly that healthcare delivery innovations cannot be adopted, or once adopted, cannot be altered or dropped. The rules should neither prevent the entry of new competing firms nor protect firms already in the market from competition. A competitive Medicare program must welcome change while ensuring that beneficiaries and taxpayers are well served. As the chairman said, the two leading examples of competitive markets in the Medicare program are Medicare Advantage and Part D. Medicare Advantage is an increasingly popular alternative to fee-for-service Medicare. Even with payment reductions mandated by the Affordable Care Act, Medicare Advantage enrollment has grown from 11.9 million people in 2011 to 16.2 million this year. More than 30% of Medicare beneficiaries are enrolled in Medicare Advantage plans. Clearly, for a growing number of beneficiaries, competitive Medicare Advantage plans are a better deal compared to fee-for-service Medicare combined with separate Medigap and prescription drug plans. Part D, as the chairman said, Part D has also been a remarkable success, and its cost has fallen hundreds of billions of dollars below CBO estimates. I'm going to focus my remarks on Medicare Advantage. My written statement has more detail about both programs. There's growing evidence that Medicare Advantage Have I run out of time? Excuse me, the lights aren't lit. Am I all right?
I think you're in good shape on time.
Okay, sorry. Evidence that Medicare Advantage plans provide higher value services at less cost to society than traditional fee-for-service. First of all, Medicare Advantage plans are more efficient in delivering care than fee-for-service. According to the Medicare Payment Advisory Commission, the average MA plan bid in 2014 was 98% of fee-for-service spending. In 2015, the average bid was 94%. That means that MA plans are willing to pay to deliver standard benefits 6 percentage points cheaper than fee-for-service can, on average, over the country. HMO plans were, of course, more efficient. Their bids averaged 90% of fee-for-service spending. Now, why are they being paid more than that? Well, the answer is the payment formula, of course. The plans are paid their bid unless they bid below the benchmark. The benchmark was set to ensure that essentially everyone would have access to Medicare Advantage plans. So it tends to be higher than fee-for-service. Benchmark this year is 107% of fee-for-service. So the amount that MA plans are paid based on their quality performance is about 102% of fee-for-service spending. But that doesn't tell you anything about the efficiency of delivering health care. That says something about the peculiarities of the payment system. Second, MA plans have a spillover effect that lowers healthcare costs more generally. It turns out that studies have shown that for every 1% increase in Medicare Advantage enrollment in a market, there's a 0.9% reduction in fee-for-service Medicare spending and a general overall reduction in spending as well on a per-person basis in the community. Third, MA plans provide higher quality care. Beneficiaries in Medicare HMOs, for example, are consistently more likely than those in traditional Medicare to receive appropriate breast cancer screening, diabetes care, cholesterol screening, and so on. And finally, the problem of favorable selection, which we've all been concerned about for many years, has largely been solved. This isn't just my opinion. This is Professor Joseph Newhouse at Harvard University and his colleagues pointed out that changes the Congress made have improved the accuracy of payments in Medicare Advantage and the lock-in procedure, the new method of risk adjustment. These are things that have largely eliminated favorable selection so that the payments to MA plans are accurately reflect the cost of providing care to beneficiaries. Competing private plans have strong incentives to provide health care efficiently and effectively, to tailor their coverage and services to the needs and demands of their customers. By necessity, private plans are more flexible and responsive to changing market conditions and consumer demands than fee-for-service Medicare. Satisfying their customers is a matter of survival. Doing so efficiently is the difference between a successful health plan and one that has failed.
Thank you, Mr. Antilles, very much. Mr. Minnesali, you're recognized for 5 minutes. I know as a constituent of Sam Johnson, our colleague here, you have great representation here in the House.
Chairman Brady, Ranking Member McDermott, members of the Ways and Means Health Subcommittee, thank you for having me here today to testify. I'm the president of Methodist McKinney Hospital, which is in McKinney, Texas. Methodist McKinney Hospital opened in February of 2010, just prior to the Accountable Care Act prohibition on physician ownership in hospitals. Our hospital is a partnership with Methodist Health System, Nuterra Healthcare, and local physicians. Methodist Health System is a nonprofit health system that has for decades taken care of the underserved in Dallas, the indigent in the south part of the community. Over 51% of our profits go back to Methodist Health System to serve those in those communities. We accept almost all insurances, including Medicare, Medicaid, TRICARE, workers' comp, most managed care plans, Medicare supplements. Our hospital employs over 119 full-time employees. We have over 230 members on our medical staff. and only 22 of those members on the medical staff are physician investors. We paid over $2.5 million in taxes last year, something not-for-profit hospitals do not share the burden in. Our services include inpatient care, internal medicine, emergency medicine, imaging, surgery, pain management, physical therapy, among many other things. We have a broad range of specialties that include pain management, gastroenterology, ENT, general surgery, medicine, and more. We have an average waiting time in our ER of just 76 minutes compared to over 2 hours at our competitors. The primary reason Methodist McKinney Hospital was developed was due to frustration with the local physicians over administration and health system management with the local hospitals. They wanted a hospital where patient care was always put first, not just the bottom line. So they decided to take matters into their own hands and build a hospital that was driven by the principles that physicians who spent their life taking care of patients held dearly. Having spent my career managing hospitals, I know one of the keys to success in hospital administration is to have good alignment between the hospital and the physicians. In a physician ownership model, I feel like we have that much more than I enjoyed when I worked in other ownership models. This culture has allowed us to endear ourselves to local physicians, nurses, and other clinical caregivers because we care about the patient first and the bottom line second. But we also care deeply about our employees and our community. We've won some good achievements and accolades to represent that. We've received 4 out of 5-star rating on CMS's Hospital Star program. We are consistently above the 90th percentile on the HCAHPS patient satisfaction surveys. We've been named a Dallas-Fort Worth Top 100 employer in 2013, 2014. We've consistently been over 100% of baseline on the CMS value-based purchasing program, and we received the Joint Commission Gold Seal of Approval on accreditation. Thanks to strong support from the community, our hospital has been getting close to capacity in some areas. That's a good problem and a bad. We're in a growing community. Collin County and McKinney, Texas have been expanding rapidly by growing more than 70% since 2000. Patients can choose to go to a lot of good healthcare providers in our community, but many are choosing us. As a result, we're now at a crossroads where our board and our partners are going to have to decide, do we leave Medicare, Medicaid, and TRICARE patients behind so we can grow the hospital and meet the growing demand in a growing community? Or do we just stop growing and stay where we are and just tell people we can't serve any more than we already are? 27% of our current patient base has those insurances. It's very discouraging to think that we could spend years trying to meet the exceptions, and I'm not sure anybody can meet the exceptions in accountable care. Even if you can meet it, it's going to be hard to prove, and you're going to have to jump through a lot of hoops. Yet our competitors do not have to do that. And we don't want to leave the seniors and the military families behind. So I would ask you to repeal Section 6001 of the Accountable Care Act so we don't have to make a decision to deny access to those seniors and military families. Thank you.
Thank you, Mr. Minnisali. 5 minutes goes fast. But we have all your testimony for the record. So, Mr. Steedley, you're recognized for 5 minutes.
Good morning. My name is Robert Steedley, and I'm the president for Barnes Healthcare Services. It's a regional home care provider based in Georgia. I also serve as the voluntary chairman of the board of directors for the American Association for Home Care, which is the national trade association for home medical equipment providers, manufacturers, and other stakeholders in the home care community. I'd like to thank Chairman Brady, Ranking Member McDermott, and members of the House Ways and Means Subcommittee on Health for holding this hearing on improving competition in Medicare. I'd also like to thank Congressman Tom Price and Congressman John Larson for introducing legislation that would create a state-of-the-art, market-driven auction system and an alternative to the current competitive bid program. I'm here today to talk about flaws in the current bids program, how those flaws impact non-competitive bid areas, and offer a better budget-neutral solution. Both the association and I fully support healthy and fair competition. My testimony also comes from firsthand experience with the bidding program at Barnes Healthcare. Opening in 1909, Barnes Healthcare Services has 106 years of experience, employs more than 300 people across 14 locations, and serves 4 states. Experts in the past have explained in great detail why the bidding program lacks transparency and restricts patient choice and access to the prescribed home medical equipment they need. I have also detailed these in my written testimony. Fortunately, Congress recently passed legislation to help fix one of those issues of the program, the lack of the binding bid. Home Care would like to thank Congressman Berry and Larson for introducing legislation that required binding bids. I'd also like to thank the Ways and Means Committee for its consideration and approval of this bill, which was included in the final SGR bill. Requiring binding bids is a key provision in the Congressman Price and Congressman Larson's market pricing program legislation, which is also known as MPP. The issues with competitive bid program are not just limited to round 1 and 2. In October 2014, CMS also issued a final rule that applies the artificially low competitive bid rates to all non-bidding areas, including rural and underserved. The artificially low competitive bid rates are only part of the problem with this final rule. The application of payment rates to non-bid areas is flawed and will disrupt Medicare beneficiary access to the home medical equipment items that they need. In competitive bid areas, suppliers try to make up for drastic cuts through increased volume. As a result of the CMS final rule, suppliers outside of those bid areas will receive the same drastic cuts without the exclusive contracts or increases in the volumes of business. There is a better, budget-neutral way to achieve market prices for home medical equipment known as the market pricing program. I've included more detailed information in my written testimony, but following are a few components of MPP. MPP includes the same items that are currently in the CMS bidding program, and it is also nationwide. There are 2 categories bid per geographic area. 8 additional categories in that same area would have prices adjusted based on auctions conducted simultaneously in comparable geographic markets. Bid areas are smaller than the metropolitan statistical areas, also known as MSAs, and are more homogeneous. Binding bids are required to ensure only serious bidders participate. The bid price is based on the clearing price rather than the median price of the winners. And finally, the same areas that are exempted from bidding under competitive bidding program from CMS will be exempted under MPP. As committee members can see from my written testimony, MPP is simply a much better auction system than the current CMS competitive bid system. MPP uses auction principles supported by economists and auction experts. It is more transparent and efficient than the current program, and it will achieve the goal of Congress to have true market prices for home medical equipment in Medicare. Home Care is very thankful when Congress Price and Larson introduced MPP in the Medicare DME Post Market Pricing Program Act in the 113th Congress. This legislation received strong bipartisan support with 180 co-sponsors. Home Care strongly supports this common sense legislation and urges the subcommittee and Congress to do the same. I'd like to thank the committee again for the opportunity to provide this testimony. Home Care and I look forward to working with the subcommittee to improve competition in Medicare while protecting patients' access to the needed home care equipment. Thank you.
Thank you, Mr. Seedling. I was just told that our normal lighting system that gives you a yellow light and a 1-minute warning to wrap up isn't working today, so I apologize for that. We'll get that back on track soon. Mr. Umdenstock, thank you for your leadership of AHA, and you are recognized for 5 minutes.
Chairman Brady, Ranking Member McDermott, members of the subcommittee, on behalf of our nearly 5,000 member hospitals, health systems, and other healthcare organizations, I thank you for the opportunity to testify today. Community hospitals embrace fair competition, where facilities compete over quality, price, and patient satisfaction. However, we're strongly opposed to the practice of self-referral, which skews the marketplace in favor of physician owners who self-refer the healthiest and wealthiest patients to their own facilities. Therefore, the AHA urges Congress to maintain current law preserving the ban on physician self-referral to new physician-owned hospitals, and retaining the restrictions on the growth of existing physician-owned hospitals. Physician self-referral is contrary to competition. It allows physicians to steer the most profitable patients to facilities in which they have an ownership interest, potentially devastating the healthcare safety net in vulnerable communities. Changing the current law would not foster competition. Instead, it would only allow these physicians to increase their profits. Current law represents a compromise that protects the current physician ownership of hospital arrangements and allows these arrangements to grow where increased hospital capacity is needed. However, some have proposed to weaken significantly Medicare's prohibition on physician self-referral to new physician-owned hospitals and loosen the restrictions on the growth of grandfathered hospitals. The AHA strongly opposes these changes, any changes that would expand the use of the whole hospital exception beyond grandfathered hospitals, or that allow grandfathered hospitals to expand or increase their capacity beyond what is allowed in current law, for three primary reasons. First, physician-owned hospitals provide limited or no emergency services, relying instead on publicly funded 911 services when their patients need emergency care. HHS's Office of the Inspector General reported that, quote, 2/3 of physician-owned specialty hospitals use 911 as part of their emergency response procedures. And, quote, most notably, 34% of specialty hospitals use 911 to obtain medical assistance to stabilize patients, a practice that may violate Medicare requirements, close quote. Second, physician self-referral leads to greater utilization of services and higher costs. CBO, MedPAC, and independent researchers all have concluded that physician self-referral leads to greater per capita utilization of services and higher costs to the Medicare program. And third, physician-owned hospitals tend to cherry-pick the most profitable patients and services, jeopardizing communities' access to full-service care. GAO, CMS, and MedPAC have all found that physician-owned hospital patients tend to be healthier than patients of the same diagnosis at general hospitals. Further, MedPAC and GAO found that physician-owned hospitals treat substantially fewer Medicaid patients. This trend creates a destabilizing environment that leaves sicker and less affluent patients to community hospitals. These selection practices place full-service hospitals at a competitive disadvantage because they depend on a balance of services and patients to support the broader needs of the community. The current payment system does not explicitly fund standby capacity for emergency, trauma, burn services, or the like, nor does it fully reimburse hospitals for the care provided to Medicaid and uninsured patients. Community hospitals rely on cross-subsidies from better reimbursed services, the very services targeted by physician-owned hospitals, to support these and other essential but under-reimbursed health services. Revenue loss to specialty hospitals can lead to staff cuts and reductions in subsidized services. In addition, many of the physicians profiting from limited service hospitals will not serve on call in the community's emergency department or participate in wider quality improvement projects that benefit the community. These facilities duplicate services, further exacerbating the shortages of physicians and allied health professionals in some communities. Furthermore, closing the whole hospital exception loophole in the Stark Law reduced the federal deficit by $500 million over 10 years, according to the CBO. Proposed changes to current law would erase those savings and raise the deficit at a time when our nation's trying to control increases in healthcare costs. Truer competition could be fostered by making common sense changes to law to allow greater care coordination and new delivery models. The healthcare field is rapidly changing, moving toward new payment and delivery models that emphasize value over volume. As part of that change, hospitals are actively exploring clinical integration, a move away from working in silos toward emphasizing teamwork to coordinate care. However, hospitals attempting to seize these opportunities to improve care and care coordination for Medicare beneficiaries and other patients face significant legal barriers. Chief among these are the outdated rules governing compensation relationships between hospitals, physicians, and other caregivers, portions of the anti-kickback statute, the Stark Law, and civil monetary penalty law. Congress recently acknowledged the need for change to the CMP law through the work of this committee in the recent SGR bill, which limited the scope of this prohibition so that a hospital is only subject to CMPs for making payments that will reduce or limit medically necessary care, We advocated for this change and are pleased that Congress lifted this barrier.
Mr. Umnestong, I apologize.
No
Time has
problem, sir.
expired by
Thank you
about
very
a
much.
minute. Thank you very much. Mr. Antos, in Washington, we like to talk a lot about cost control. Washington sort of setting prices and then determining whether it's the right amount or if you deserve this. You talked about competition as a more patient-centered way to find savings and efficiency. Can you talk about, briefly, I have questions for our members or our witnesses. Can you talk briefly about which one better serves seniors while creating savings?
Thank you, Mr. Chairman. It's certainly the case that the fee-for-service incentives are to expand volume of services and to focus only on the part that you, as the specific provider, whether it's a hospital or a physician or some other provider, but only your part of the patient's health care. So, in fact, I found that Mr. Umdenstock's point about expanding services, I believe that is endemic in the Medicare fee-for-service system. If you don't provide services, you don't get paid. As far as competitive programs, doing a better job of serving patients and giving patients what they want, which is not only a good financial deal, but also good patient outcomes, then you really have to go to kind of private plans that I think we see in much of Medicare Advantage, where they look at the whole patient. Now, short of that, fostering real competition, avoiding having CMS or Congress set prices when, in fact, we don't know what the prices are. All we know is what the charges are. We need to introduce more competitive approaches in traditional Medicare, but ultimately, I think we're going to have to move to a more coordinated system. Medicare Advantage is on that way.
Mr. Antos, thank you. I noticed that in the prescription drug program, the Democrat alternative to the Republican plan set a monthly premium of $35 for Medicare Part D. Here we are 10 years later after, and through cost increases, prices, all that, the average price is still below the cost control price set originally by the alternative through competition.
That comes from several factors. Perhaps the biggest factor is the competitive effect. The different drug plans know that if they're going to make money, they have to attract customers. If they're going to attract customers, they have to offer a good balance of access to drugs, including expensive drugs, and low cost. The remarkable thing about this program really is that, as you say, we've seen premiums basically stay level for the last 10 years or so. That's partly due to the fact that we have seen a slowdown in the introduction of expensive new drugs. But importantly, Part D plans have really encouraged Medicare beneficiaries to use generic alternatives.
Great.
That has been very effective.
Thank you, Mr. Sanchez. Mr. Minnesali, thank you for being here. We are told the problem with physician-owned hospitals that they don't have an ER, that they self-referral, so there's greater utilization among themselves and higher costs, and that you cherry-pick the patients who come through your door. Can you talk a little about your experience? I think you've served both in for-profit, nonprofit, now physician-owned hospitals, so you've seen the operations and all those models. Your thoughts?
Yes, sir. First, I want to mention, in terms of cherry picking, it should be pointed out that we serve TRICARE. We're a TRICARE provider at our facility, and one of the two largest health systems in the Dallas-Fort Worth area is not a provider, and I guarantee you we're not doing that because of the high TRICARE payment levels. So that would be one example of cherry picking. We do have an ER, and we have advertised it since we've been open on an ongoing basis to try and get more people to come in and open those doors up. Also, as you mentioned in previous positions, I've been responsible for facilities in the southwest side of southwest side of San Antonio, where we had physician ownership, and it was a very large indigent population there, underserved. Same situation in Congressman Eddie Bernice Johnson's district in North Houston, where we had physician ownership, in Port Arthur, in Odessa. And these are full-service hospitals with physician ownership that didn't have the opportunity to cherry pick.
You're 4-star rated CMS,
Yes, sir.
correct?
Yes, sir.
And that star rating takes into effect the complexity of the patients you're serving, correct? So, if you were cherry picking, in fact, you were punished in that star rating, correct?
Yes, sir. And I would point out that many of the physicians that work at our hospital bring most of their patients to our facility. Obviously, we're a 21-bed facility, so they can't bring 100%. But yes, I think in our circumstance, the cherry picking is greatly exaggerated.
How many times have your hospital called 911 for emergency services?
Actually, we have a process for strokes and for, we have a code STEMI, which those are the situations where, like there are certified stroke centers and certified heart centers, where time is of the essence, where we need to get that patient transferred to the highest level of care possible. In fact, there are not a lot of stroke certified centers, even along the larger hospitals in our area.
So when you dial 911, it is to get the patient to the highest certified, qualified local provider?
Correct. Correct. And that's been very rare, but that has happened a few times. I'd probably say 3 times in 5 years, maybe, for us.
Thank you. Mr. Umnestock, you raised points we've heard as concerns. That these hospitals don't have functioning ERs, that they refer to each other as physicians, and they cherry pick. Looking for common ground and recognizing that in the decade since this temporary moratorium was put in place, for-profit, nonprofit hospitals have increased their beds easily more than double all the physician-owned hospital beds in America. So you're allowed to grow to meet the needs of the community, which seems to me to make good sense. So the common ground here with physician-owned hospitals, I can guarantee you that they're all not in the best parts of town, while I've noticed nonprofit and for-profit do grow to meet the needs of the community. So would a compromise be if physician-owned hospitals had a functioning ER, that they are shown to not self-referral in high utilization by CMS, and their STARS rating prove that they are not cherry-picking but meeting the needs of their community? Is that an area where this discrimination against one model could end and we could have competition among all the hospitals? Is this a common ground you would consider?
Excuse
Can
me,
you get
sorry.
that microphone?
Mr. Chairman, thanks for the question. Just a couple of points, first of all. As recently as the cab ride over here this morning, double-checked the website for Methodist McKinney Hospital relative to the ER, and it says that our emergency department offers quick care for all of your bumps, sprains, and minor injuries, 365 days, 7 days a week. Now, that may be a very important urgent care function that's good for that community, but that doesn't sound like an emergency department to me.
Mr.
number one.
Minisali, since this was raised, so you only treat bumps, scrapes, and bruises in your yard?
Absolutely not, sir. As I mentioned, we're not a stroke center, we're not a heart center.
Sir, from their own website, from the Medicare cost reports in 2012 and 13, percentage of Medicaid, talking to the question of patient and payment selection. In 2012, the Medicare cost report showed 0 Medicaid patient discharges, and it grew to 0.4% in 2013. So very, very skewed payment system. So that's the issue, sir. And that's what we're here to urge Congress to stay with. Stay with a program that limits the growth of these hospitals where they are highly selective and picking off the most profitable services. You notice the services on which hospitals like this focus. And I understand why. That's where the payment is. But
Well, let me
community
ask you
hospitals
this.
don't have that opportunity.
I respect your opinion. Thank you so much for being here. But the STARS rating program takes into
Yes,
account the types of patients these hospitals treat. So are they incorrect in their assessment, or are they fairly accurate?
Yeah, number one, the STARS rating program focuses on the HCAHPS scores, the experience of care or patient satisfaction as we commonly refer to it. If you have the opportunity to identify which patients are going to come to your hospital in advance, you can prepare those patients for that experience. Hospitals, general service community hospitals, full service community hospitals, receive over 60% of their admissions through the ER. It's not a predictable source of who the patient is, number one. Number two, if you're not treating a full array of patients from all socioeconomic strata, you're likely to have a much higher satisfaction rate.
But is that the criteria for adding new beds?
It's
That hospitals of all models should only go to areas that have a broad, certain percentage of Medicare and Medicaid patients, that ought to be a criteria that's applied. If it's applied to physician-owned hospitals, for example, should that be applied equally? Should this moratorium be applied to all hospitals equally to ensure that each facility meets a broad range of patients?
The current criteria for an exception recognizes several factors, but one is that the particular hospital in question serves at least the average or greater proportion of Medicaid patients as other hospitals in its area. That's already there.
Yeah, I agree. Would that be a fair restriction on all hospital increases in beds?
Well, it's not a matter of whether or not it has to be a requirement. Every
Well,
full-service
but it is
hospital
for physician-owned
within-
hospital. I'm just trying to find, again, common ground, because I know, look, hospitals are serving both, areas of town that don't have necessarily a good culture of healthcare, and then they can serve areas perhaps with higher private pay. They do that as systems, again, to try to make ends meet and try to meet their missions, either nonprofit or for-profit. And the question is, why shouldn't this model be able to do the same thing?
I think you'll find that if you look across the nation's full-service community hospitals, on average, they have about 15% of their patients, plus or minus, that are Medicaid, about another 25 or more that are Medicare, probably about 10% prior to the ACA expansion of coverage. Admittedly, that number's going down, but about 10% no pay. And so those hospitals are already taking that type of mix of patients. So I don't see a need to require it. They're already experiencing it.
So, but you would be comfortable with a requirement of those types of services for new beds in all hospitals? Should we apply this goal of broad community service to all hospital beds?
I'd like to go back to your context that you used to set up this point, sir, if I might, which was that hospitals nationally have, believe you said, opened more beds than the total number of beds in the 250 or so physician-owned specialty hospitals. Number one, that's a very small percentage of the national bed complement. Number two, that may be true that some hospitals have grown at that rate, but we've also seen hospital closures across the full-service hospital spectrum in many areas, including in Texas, sir, as I know you're very familiar with. So I don't think that that's a rampant problem of hospitals adding more beds. In fact, hospitals are trying to figure out how to skinny down their inpatient complement so that they can focus more and get more patients served in outpatient and out into the community. So we're actually seeing the reverse phenomenon of the description. They're actually de-emphasizing inpatient care, particularly as they are more at risk financially.
I recognize that. I hope you'll come to Houston sometime to see the growth of hospitals. We're thrilled with it in my community and throughout the area, and it tells a little different story. So again, looking to find common ground. I know what the concerns are, and I think we need to have good discussion on this. Ranking Member McDermott, you're recognized.
Thank you, Mr. Chairman. It's an interesting discussion we're having here about, and this is not to pick on one hospital, but it's an example we have in front of us here today, McKinney Hospital. Now, a hospital, why would a hospital want to be a specialty hospital? Why would they just want to do certain things? Mr. Ummenstock? I mean, you got 5,000 hospitals, so give me why would a hospital specialize in only doing orthopedics or only doing cardiac or whatever?
Well, I assume that there are several reasons, one of which might be that the focus of energy and resources, volume in order to improve technique and outcomes. But also, I would say that you have to recognize that the particular services that limited service hospitals focus on are the profitable services. I don't have a lot of competition for the non-profitable services inside full-service hospitals.
What are the profitable services for hospitals?
Well, certainly you see procedure-oriented services, so surgeries, speaking broadly, other forms of procedures as opposed to medical services. Certainly your own specialty of psychiatry would be at the other end of that spectrum.
So if a hospital had 83% of its patients were in for surgery, there would be somehow they would be skewing it in that direction to make it, that's not the average in most hospitals across the country, is it?
That would not be reflective of the average complement, the average balance of services, that's correct.
So in some way, they've selected who comes in by the services that they offer. Is that correct? Is that how the specialty hospital works?
With that kind of imbalance, one would have to assume.
And if you talked about the emergency room. Now, I like you, I use the internet, and I think all modern people use the internet. It says here that for Methodist McKinney, if you were experiencing any of these conditions, please call 911 immediately. Life-threatening conditions, heart attack or stroke, open fractures, severe bleeding, signs of heart attack or chest pain, head injury or other major traumas, one-sided weakness or numbness, loss of consciousness, severe abdominal pain, uncontrolled pain or bleeding, poisoning, call the Poison Control Center. Now, if an emergency room is not going to deal with those issues, can that be called a full-service? I mean, what it says they do take care of are stitches and staples for cuts, gashes, and wounds, x-rays, fractures and sprains, abdominal pain for maladies such as appendicitis, colitis, and pancreatitis, and general illness treatment, virus, flu, and dehydration. So it's kind of a doc in the box, it sounds to me. They say they have a doctor on call. Is that how that sounds to you when you listen to that description?
I would say, Mr. McDermott, that full-service community hospitals run toward problems, trauma, emergencies, and want to be of immediate service to people. If they have that type of condition, that's exactly the type of person we expect to see at our ER. So that would be, that's our purpose, and that's why we're there. Granted, we often have to then transfer the most acutely ill to the higher levels, full-service hospitals or teaching centers. But yes, those are the kinds of things that we would expect to see and that we do see in full-service community hospital ERs.
Now explain to me exactly how the Stark Law operates in a specialty hospital. The doctors own everything. They own the MRI, they own the CAT scan, they own all the machinery. They can refer every patient they want to their own CAT scan or their own MRI. Isn't that correct?
And that's correct. They're free to decide where to refer that patient.
Stark Law prevents you from doing that if you're in another hospital where you have an MRI that's away from it. that you own or own a piece of, you can't refer your patients to that MRI. Isn't that correct?
That's right. It's called the whole hospital exception, as was pointed out earlier. You have to own a share in the whole hospital.
You have to own the whole thing. And that's really what we're trying to stop, and have successfully stopped and saved $500 million.
According to
500 million.
CBO. That's
According to
correct.
CBO. By the way, I want to say, I know this is this may be your last appearance before this committee. You've been working as a CEO for AHA for 8 years, and we thank you for your service in this large organization. It's a tough job that you've had, and we appreciate your work.
Oh, thank you, and thanks to the chairman as well for those sentiments.
No, I appreciate it. Thank you very much for, just, Mr. Minnesali, we're 1,200 miles from your ER. You were Mr. Johnson's witness. Do you want to address the claims you just heard about your ER?
Yes, sir. First of all, I would certainly appreciate any ideas or support from Representative McDermott or Mr. Umdenstock on how we could grow our ER business. As I've stated, we've not been very successful. We've advertised and advertised and advertised, and that is how a lot of those admissions do come into the larger hospitals. We've also seen a proliferation of freestanding ERs open up in our community. HCA open to in the area. There's several others. And so anything we could do to grow the ER and get more admissions, medical or otherwise, would be great.
Thank you. Mr. Johnson, you're recognized for 5 minutes.
Thank you, Mr. Chairman. Mr. Minnesali, thank you so much for testifying today. I appreciate hearing all the great things Methodist McKinney is doing back home. I want to ask, given your unique experience, what do you believe the biggest difference is between physician-owned and other hospitals?
I think really the directives of when we're making decisions, there's kind of a hierarchy in the physician-owned hospital where I'm at is patient care is first, physician desires second, employees are third, and profits fourth. In previous experiences where I worked for other company, we were usually driven by corporate health system goals and profits.
Thank you. Mr. Umdenstock, thank you for your testimony today. I have a handful of questions, so in the interest of time, I ask you please keep your answers to yes or no, if you would. First, are you aware that your testimony refers to GAO, MedPAC, and HHS reports that are 8 to 10 years old and only studied specialty hospitals, not all physician-owned hospitals? Is that yes or no?
This debate has been going on that long, and we've tried to reference all sources that we can find throughout the last 12 years.
Well, you didn't answer my question. So in your testimony, you argue that physician-owned hospitals cherry-pick patients. But did you know that after the GAO and MedPAC reports were released, CMS changed how hospitals are reimbursed, so a hospital is paid based on the severity of the specific patient, which means you can't cherry pick. Is that true or false? Okay, don't answer that either. Thank you.
You
I'd
can
also
cherry
like to
pick
refer
in the
you
way
to
you
the-
refer patients, not in the way a particular patient is paid for, sir.
Okay, I'd also like to refer you to the first quote on the screen from a health affairs study stating physician-owned ownership is not a driving force in referring patients to specialty hospitals. I request that the full article be submitted for the record along with additional references.
Without objection.
Thank you. Now let me ask you, do you believe that physician-owned hospitals destabilize community hospitals, yes or no?
Yes.
Okay, I'd like to now refer you to the second quote on the screen by the Federal Trade Commission on the importance of competition in Medicare. I'd also like to highlight that the August 2006 MedPAC report your testimony cites stated that profit margins for community hospitals in markets with physician-owned hospitals were higher than those in markets without physician-owned hospitals. Next question, do you believe that physician-owned hospitals lead to greater utilization of service and higher cost, yes or no?
Yes.
Thank you. I'd also like to submit for the record a list of cases with over $3 billion in fines paid by non-physician-owned hospitals for the very things you claim physician-owned hospitals do. I think you have those, Mr. Chairman. I'd also like to submit for the record a statement by the Federal Trade Commission saying that physician-owned hospitals increase competition and reduce prices. Lastly, I'd like to submit for the record a study that shows physician-owned hospitals save Medicare almost $10 billion over 10 years. Finally, your testimony argues physician-owned hospitals should not be allowed to expand because they offer limited or no emergency service. But isn't it true that Medicare does not require emergency departments, but actually only requires Medicare providers, including physician-owned hospitals, to comply with conditions of participation and the Emergency Medical Treatment and Active Labor Act? Yes or no? That's for you, mister.
For me?
Yes.
Yes, when 60% of your patients come through the ER, ER is a very important part of a, quote, hospital. I would agree.
Mr. Chairman, thank you for holding this hearing. I'm not here today to criticize one Medicare provider over another, but instead to discuss the important role physician-owned hospitals play in promoting competition in Medicare. Instead of continuing the Obamacare prohibition on these hospitals, which was included in the 2,000-plus page law as a political favor to the American Hospital Association and others, we ought to allow patients access to the high-quality and lower-cost care provided by physician-owned hospitals. In America, we let competition pick winners and losers, not the government. I'll yield back the balance of my time.
Thank you. Mr. Thompson, you're recognized.
Thank you, Mr. Chairman. Thank you to all the witnesses for being here. Mr. Chairman, I'd like to ask unanimous consent to enter a letter into the record from the U.S. Chamber of Commerce, who wrote stating that defending America's free enterprise system, they're in opposition to the self-referral to physician-owned hospitals.
Without objection.
Thank you. Mr. Minnesell, I'd like to follow up on the questions that both the chairman and the ranking member had asked you and give you an opportunity to respond. They were referencing the type of services that your particular hospital does or doesn't provide. And the CMS data that I'm looking at tells us that about 70% of physician-owned hospitals, fewer than 5% of their admissions are Medicaid patients, and a little over 20% admitted no Medicaid patients at all. And your hospital specifically, and I think that's what they were asking you about, in 2013 had 24% Medicare discharges and 0% Medicaid discharges. Can you kind of explain why these hospitals in general and yours in specific, and they're often located in proximity to full-service hospitals, aren't treating Medicaid patients? And isn't there a need to do this in these underserved areas?
I assume you're not, I'm not sure about the data you're citing, but I assume you're not referring to the hospitals in North Houston, Odessa, San Antonio, Port Arthur, that had physician ownership that I've managed in my career.
No, I'm talking about the hospital where you are now, Methodist McKinney. You had 24% Medicare discharges and 0% Medicaid discharges?
Yes, sir. That is geography. In my experience, the Medicaid population tends to go to the closest facility due to transportation challenges. And we happen to have built the hospital in an area where there's not a indigent population.
So it's all geography as it pertains to your hospital?
I cannot say it's all. There is we are a Medicaid provider. There is now a McKinney bus service that could bring them there, and we're happy to take care of them. So I can't, other than advertise, have our doors open, let the bus come over. I don't know how you make patients come to your facility.
Thank you. In my home state of California, we have hundreds of community hospitals, and there's no shortage of competition, competition that's operating on a level playing field. I've got some concerns about the self-referral model. And in my full-service hospitals at home, they compete on the quality of their service, the geography, and their reputation, not on whether or not physician owners will win, financial gain as a result of this. And I worry about changing this law and what it would do to destabilize the continuity of care that we have in my area and others. Mr. Umberstock, I don't have any of these hospitals in my community right now, and from the testimony that I've heard so far today, I don't think I want any. But if the law were weakened and they could come in, what do you think the impact would be on my constituents and the other constituents in other areas that don't have this type of unfair competition?
Well, I think it's the three things that I mentioned. One is that the patient mix and service mix will shift in your community. It could very well jeopardize the ability of full-service community hospitals to continue to provide a full array of services. There's certainly the question of increased utilization and therefore increased cost, and there's competition for employees who are already in short supply, as we all know. So I think that we've got serious concerns about that. And there is an exception process. So if a hospital feels that it needs to grow and it's in a growing area and there is a high inpatient census on utilization and they do take a high proportion of Medicaid patients, CMS has already approved one. I only know of 2 applications. They've approved one and one is pending. So there's a mechanism to handle that.
What about the current law that requires physician-owned hospitals to report annually to CMS about the ownership and all the particulars? It's my understanding that that hasn't been done. And aren't we putting the proverbial cart before the horse with trying to do this legislation without first having all the data necessary to be able to assess what's actually going on?
I do know from what's up on the CMS website that they say that they have had a very low rate of response to their reporting requirements, so much so that they've yet again extended the submission deadline. So apparently they're having trouble identifying those ownership and other indicators that they require. So one would think that that would be important information to have, yes.
Okay. Thank you. Yield back.
Thank you, Mr. Smith. You're recognized.
Thank you, Mr. Chairman, and thank you to our witnesses here today. I appreciate the insight that each and every one of you bring to the table here. Certainly, as a representative of a part of rural America, I can appreciate the challenges facing healthcare, facing the financing of healthcare. I have been here long enough to observe a lot of the arguments for and against various components of public policy as it relates to healthcare, and certainly as a consumer from time to time of healthcare. And as a patient, I think it's important that we observe what's going on. Now, I get very concerned when there is an agenda of prohibitions and mandates. That could be inside Obamacare or even beyond that. But I get very concerned. I know I've been working on an issue with critical access hospitals in my district with the 96-hour pre-certification requirement that I think is burdensome, it's unnecessary. And yet it's part of the list, the long list of prohibitions and mandates that exist in healthcare. And I would hope that we could have flexibility in our healthcare. I know that living in a community where we have, I think, a very vibrant community hospital, regional hospital, along with a federally qualified health center, and even some options for patients that would involve walk-in urgent care. I see the flexibilities that allow those to be used by patients. That's a good thing. It is hard to say, perhaps, I mean, I don't know the exact financing mechanism of every patient, but I was just wondering if anyone could speak to the fact of prohibitions and mandates leading to actual cost savings, if any of our witnesses would like to answer that.
Yes, Congressman, I'd be happy to. Number one, this is an arrangement that has been arrived at over a discussion and a series of compromises over a dozen or more years. So this is an ongoing conversation in this industry.
But it's a result of a compromise?
Where we are today is
The prohibition.
the result of starting with this limits on future new entries and limits on growth for the grandfathered hospitals. Yes, this has been an ongoing conversation since at least 2003 that I'm aware of, probably longer, number one. Number two, the CBO has scored that this particular provision in the Affordable Care Act saved $500 million over 10 years. So yes, it is a, quote, saver at the moment, and changing it would require, obviously, in the CBO's opinion, unleash additional spending that would have to be paid for in some way under the Medicare program.
You said at least at the moment. So long-term, do you think that we need the current prohibitions and mandates that are currently in place?
Yes, and I think that we could ask CBO to score it again, but I think I don't see any reason why for the next 10-year segment they would come out with a substantially different answer.
Okay. Anyone else wishing to respond?
Yes, sir. You mentioned cost and the prohibition. One thing that we've seen is our competitors employing physicians. When 5 of our original physician investors' practices have been bought out since we opened, and many, many more in the community. And my understanding, there's data showing, I believe it's in California from CMS, that actually increases cost. It doesn't decrease cost. So I think the elephant in the room, and there's also our competitors are spending a lot of money on paid medical directorships to the high-paid proceduralists. We don't pay medical directorships. We don't employ physicians. I believe those things are part of the reason the data shows costs are going up. We would tend to focus on competition and quality that would lower costs and provide better care in the end.
Okay, thank you. Anyone else wishing to comment? Thank you, Mr. Chairman. I yield back.
Thank you, Mr. Davis. You're recognized for 5 minutes.
Thank you very much, Mr. Chairman. You know, for many, many years, we've had a great deal of conversation relative to how do we improve quality and contain cost at the same time. If we are still experiencing 60% hospital admissions through emergency rooms, does that say that our system needs to do anything in order to try and get to this real notion of cost savings?
Yes, Congressman, thanks for that question. It does indeed, and that's why the American Hospital Association and our 5,000 members are very much interested in new payment and new delivery system models. It would indicate, as you say, that people are dropping into the healthcare system on an as-needed or ad hoc basis, not with any sort of long-term relationship to the system, and certainly not a relationship that emphasizes early intervention, prevention, wellness, community-based services, and so on. We believe that that's the right way to organize the system. We're trying to do that by coming together with other entities up and down the continuum of care. As I mentioned in my oral statement and in our written testimony, there are significant legal barriers to doing that. But ideally, that's what we would do. We would put the incentives for wellness and less utilization and align them between patients and providers.
Dr. Antos, could I ask you, isn't it true that current law does not necessarily restrict or does not prevent increases in certain types of hospitals if they are needed in areas?
That's right, Congressman. There are exceptions. They're limited. I assume we're talking about specialty hospitals now or physician-owned hospitals. There are some exceptions. However, effectively, the law, the provision under the Affordable Care Act, effectively eliminates any chance that physician-owned hospitals can expand or that new ones can be created. The exceptions are very, very rare.
Is it not also true that in many areas, many states, that locally determined decisions are made through health facilities planning boards and other entities that will allow or not allow a hospital to build or a new service to come in or a new service to start?
That's right. Certificate of need is the phrase. I live in Maryland, and Maryland has a certificate of need law. I have to say, my observation of the state of Maryland is that it's a difficult process, and it's not at all clear that in the end you end up with decisions that would have been made in the market, decisions that would have been made by consumers as far as where they would choose to go for services.
And Mr. Umdenstock, let me ask you, current law requires physician-owned hospitals to report annually to CMS on their status and to provide a detailed description of the identity of each owner or investor in the hospital and the nature and extent of all ownership and investment interests. But the CMS website still does not include this information, and CMS says that they are concerned about the accuracy of the data they have received. So the agency has once again extended the deadline for submission. Of course, this means that the public has no data on how many of these hospitals actually exist or who the ownership actually might be. Do you think we ought to have that information before making further decisions about the issue?
Yes, sir. Yes, Congressman, I do, absolutely. Hospitals, again, full-service hospitals are under very rigorous reporting and disclosure requirements to the government about such issues, and I think it's disappointing that a particular segment hasn't been able to come up with that information, at least, again, as I referenced the CMS.gov website. So they're obviously concerned, and yes, I would think that that's important information to have before any significant changes are proposed.
Thank you very much. I see that my time is about to expire. Thank you, Mr. Chairman. Now yield back.
Thank you. Mr. Marcy, you're recognized.
Thank you, Mr. Chairman. I represent a district in around the DFW airport. We're very blessed in that we have several major hospitals that would be represented by your organization, but we also have an explosive growth in very highly technical, customer-oriented private physician-owned hospitals. And in my particular district, there is a great demand for that hospital. They are responsive. They seem to be a little more agile in filling market niches. They seem to be more responsive in whole to parts of my community. Mr. Umdenstock, where one of your hospitals is a partner with one of these physician-owned hospitals, what is the AHA's approach to that? How do those partners deal with this situation where they in fact are providing the capital and many times the loan and everything to start this other hospital, which is the case in my area?
Yes, Congressman, thank you. First of all, I would point out that some of our member hospitals are in such partnerships, as is the case present here today. The Methodist Health System is is an AHA member and a fine member and a fine organization. We're very pleased that they have maintained being an AHA member and participate in our broader discussions and debates. When we formulated our position on this, it was through a very participative process of hospital members with specialty hospitals and those without. And frankly, on this point, some of my members have agreed to disagree. So the situation is the same, whether it's a freestanding or partnered entity, and our position is the same. It's not been an easy position for us to take. We respect all of our members, but it's one that the vast majority of our members support.
But that would explain why the major hospitals in my district perhaps are not coming to me and saying that we're for this moratorium. In fact, many of them are telling me.
I have members in metro areas, or I haven't looked at it by congressional district, but more broadly on SMSA basis and so on, where they have very different views. Some, as we saw during the debate of this particular provision, very much opposed to it. Others had made investments and were supportive of it. But I can tell you, sir, that the vast majority of our members are not in favor, are supportive of current law and not in favor of relaxing it. Not an easy position for us, but one that the members broadly support very strongly.
Are you familiar with this group of hospitals across the nation that during the formulation of the Affordable Health Care Act, they started facilities, they had hospital wings or additions in various stages of construction, and when the Affordable Health Care Act was put into place, the commissioner decided that on a certain day, if those beds were not certified, and accepted that those beds would never be basically accepted for Medicare or Medicaid use.
The act was enacted in March of 10, and people had the ability through the end of December of 10 to bring these online and get a Medicare provider number. So in the law, there was a 9-month delay. In reality, there was a longer delay because this provision was always on the table and being debated. I was having conversations with my own members, again, some of whom were making these investments in these organizations who wanted to know what that date would be. So people were on notice because of the conversation for much longer than 9 months. But that date was in the law.
The
yes.
fact is that several hospitals were caught in this period of time and now have beds that they fully intended to use for Medicare and Medicaid patients. But because of the prohibition, because they were excluded, cannot use them for that purpose. Is it the position of your organization that these hospitals never be recognized and never be allowed to use those beds for Medicare and Medicaid patients?
That was the provision of the act. We're supportive of that provision. And again, it was several years in the making, so there was a lot of lead time in that respect. We were counseling our own members that it was a very high-risk proposition. Given the support for this measure, it would be a very high-risk proposition to keep going. Some members actually got their hospitals opened in that period of time. Others found themselves not able to do so before the well-publicized deadline.
Thank you.
Thank you, sir.
Mrs. Black, you're recognized.
Thank you, Mr. Chairman. I want to thank all of the panelists for being here today. Very interesting conversation on 3 very important issues. Mr. Anthos, I want to turn to you, particularly about the Medicare Advantage plans. That many critics have suggested that the Medicare Advantage plans are overpaid and they don't provide a service that is more valuable than the fee-for-service. We have seen enrollment in Medicare Advantage plans all the way across the country, and I know in my district more than triple over the past decade. And I know that what I hear from folks that are in the plan, and the surveys show that seniors are more satisfied with their Medicare Advantage than they are with their fee-for-service programs. All this has occurred while the Medicare Advantage has been cut dramatically. We see that continuing, and in some cases where they said they were going to cut it dramatically, and we've seen a little bit of a reduction in that, so they weren't cut quite as dramatically as what was talked about. Do you agree that this competition, that Medicare Advantage is overpaid for their services it provides? Do you agree with what's being said, that they are overpaid?
No, I don't agree. I mean, the fact is that Medicare Advantage plans do provide good value, not just for the people who enroll in them, but also for the taxpayer. You know, one of the interesting facts about this is that people say that it's the younger Medicare beneficiaries, the ones who turn 65, who are the new enrollees in Medicare Advantage. Actually, that's not true. It turns out that most people, when they turn 65, sign on to traditional Medicare. And after a few years, they often find out that that isn't the plan they want to be in. It's not a health plan as they know it, because they've spent 30 years in more organized healthcare delivery systems. So in terms of value, I mean, there's very little question here. The fact that the bids, the amount that they bid is below the cost of fee-for-service across the country says that Medicare Advantage plans are able to provide full Medicare benefits at a lower cost than fee-for-service. The fact that they get paid more gets plowed back into additional benefits for beneficiaries.
Well, and I'm also interested, I heard you at another event talk about this very subject matter. And in addition to that, one of the things that you did talk about is the research that you've done that suggests that the effects of the competition have actually seen the Medicare Advantage programs have that spillover effect on the fee-for-service. And in both lowering the cost and the increasing of the quality. Can you talk just briefly about what you've done as far as the research there and how that has affected the fee-for-service in lowering those costs and increasing quality?
So, you know, an important point for all of us to remember is that seniors are in fact the biggest customers of the healthcare system. And so if the senior population, if the treatment for the senior population becomes more efficient and more effective, that's going to spill over on everything else that the health sector does. In essence, what's happening is that Medicare Advantage plans are introducing better systems of coordinating care. They're especially focusing on the people with serious chronic diseases, the people who are the most expensive in the system. And when you have a sufficiently large volume of patients who are in those organized systems, well, it turns out that physicians also operate in the fee-for-service sector as well. They don't change their practices just because the paycheck, which is going to go to some business office, comes from someplace else.
And Mr. Intos, if I may, because I only have a couple of seconds left, I think this really makes the point of what we have been talking about, that when we look at the Affordable Care Act, we talk about repealing and replacing with something that's more market-based and something that's more patient-centered. And I think this is such a great model when we look at the research that's been done to say when you do that, when something is more market-based and more patient-centered, we see a lowering of costs at the same time an increasing of quality. And so I'm just really very interested to see more research done in this area that can show that if you do that, the fee-for-service will actually follow, because there is going to be competition on the other side to make sure the costs come down, but the quality is there. Thank you so much, Mr. Chairman, for having this hearing today.
Thank you, Ms. Black. Mr. Khan, you're recognized.
Thank you, Mr. Chairman. Thank you for having this hearing today. I thank the panelists for your testimony. Mr. Chairman, the reason I was late getting to the hearing this morning was I had a few interesting meetings on the current long-term care system and market that we have in the country. And I think this is another area ripe for oversight and some additional hearings so that we come to grip before the Medicaid program absolutely implodes due to where we're going with long-term care in this country. But Mr. Umdenstock, let me start with you. And staying on the self-referral physician-owned hospital track, you cited in your testimony, both written and oral here today, that there are numerous studies from CBO, from MedPAC, from other independent researchers citing that with self-referrals at least, they're seeing data that's showing that they have an increase in utilization in both services and therefore costs in the Medicare system.
My question is if there are ways for us to accelerate reform within the payment area so that we are getting to value, quality, outcomes as opposed to fee-for-service, whether that would help address the overutilization that you cited and that apparently exists based on these numerous studies out there.
Thank you, Congressman. Yes, overall, the AHA is very supportive of the various payment demonstrations and experiments that are going on at the moment to try to figure out a better approach to financial incentives that'll drive a better organized and more coordinated delivery system so that we can move toward that system. Unfortunately, right now, nobody has come up with an agreed-upon approach to do that, so we find ourselves with experiments and demonstrations in accountable care organizations and primary care medical homes and so on, all very important learning experiences, and hopefully based on that experience, we'll come to more of a consensus on how to move off to the next payment system.
You know, I've enjoyed working with many of your members and those in Wisconsin in particular that have been moving to a more integrated, coordinated patient center and have been real drivers in value in the healthcare system and that, but they share a frustration that I've had for some time is how can we accelerate this? How can we move from fee-for-service to more value, quality, and align the financial incentives done the right way? You mentioned the accountable care organizations. Secretary Burrell just announced an expansion of the Pioneer ACO program, which I think is helpful. The medical home models, maybe some bundling in that, but are we just still in this era of experimentation and trying to find out what works and what doesn't, or are there some payment reforms that really do show some promise that maybe we ought to be stepping on the gas pedal a little bit harder on?
Well, certainly, again, as you mentioned, from your home state, a very much one of an integrated delivery system, large groups connected to hospitals, connected to payment systems. Just tomorrow, I'm going to meet with members from across the country who are in very similar models to that. We estimate that about 20% of our members at the moment, maybe high teens, getting to 20, have a health plan or have some sort of relationship to a health plan where they're starting to integrate payment and delivery. So the more we see of that, the more we see coordinated, integrated systems of care emerging. And so we're supportive of that. The only problem is that that's not right for every market yet. It's very difficult to do on small population bases, for example. Very difficult to do if the payment isn't right in socioeconomically disadvantaged urban areas. And so it's a concept that we're all very interested in and moving toward, I believe, but it's all a matter of markets and timing.
What are you seeing in the area of the uncompensated care numbers right now? Obviously, there's some improvement in some states, but I hail from a state that's rejected the Medicaid expansion funds and has left us with a huge shortfall in that regards. But overall, what have you been seeing?
It's much more favorable, as you might expect, in states that have chosen to expand Medicaid. Nationally, we believe that uncompensated care has dropped, or charity care has dropped about $7.5 billion with the additional coverage, and about 2/3 of that, maybe about 5 in round numbers, is from Medicaid. So we definitely continue to urge all states to take advantage of that option, and it works for the states, it works for communities and employers who have a backstop if people should lose insurance, and it is working and helping providers as well.
Finally, I know I'm running out of time, but I'd like to follow up with you in regards to one of your recommendations for improvement, the standardizing the merger and review process between the two Fed antitrust agencies. I think that's a huge area that is going to require more scrutiny by all parties involved, so I'd like to follow up with you on the future with
We'd
that.
be happy to. Big
Great.
issue. Thank you, sir.
Thank you, Mr. Chairman.
Thank you, Mr. Jenkins. You're recognized.
Thank you, Mr. Chairman. Like many Americans, I'm concerned about the future of the Medicare program. The current trajectory of Medicare shows a trust shortfall in 2031, only 16 years from now. This impacts not just future beneficiaries, but many current beneficiaries as well. Access to quality care is in jeopardy, and that's why this hearing really is so timely. Improvement of competition in Medicare has the potential to lead to lower prices, higher quality, and more sustainable future for the program. One area of Medicare that has already demonstrated these results is the Medicare Advantage program. And the latest numbers show that over 62,000 Kansans enrolled in a Medicare Advantage plan last year. These private plans compete against each other to offer beneficiaries increased coverage options, particularly in rural areas. A Rural Policy Research Institute study shows that 216,000 more rural beneficiaries chose a Medicare Advantage plan between 2013 and 2014. This is despite the cuts to Medicare Advantage in the President's health care law and despite the shrinking rural population in America. So, Dr. Antos, Representative Black already touched on a few of my questions, so maybe I'll just pick up there. How do you explain this apparent discrepancy between the President's cuts to Medicare Advantage and the increased popularity of the program?
Well, I think it's a tribute to the poor performance of the fee-for-service program in Medicare. As I mentioned, part of the issue is that once you get to know Medicare, you realize that it isn't the program you thought it was going to be. And I think this explains to a very large extent why there's been such an expansion of enrollment among the younger Medicare beneficiaries. Now, it is the case that Medicare Advantage plans are much better organized as businesses than the various unconnected fee-for-service providers. And so one of the criticisms that is sometimes made is that, well, they're overbilling, but they're not overbilling. They're in fact properly coding the maladies and the conditions of their customers, and they're not only properly coding that, but they're also fully incentivized to find ways to provide kind of 360-degree care rather than narrow focuses on hospital services or physician services or what have you.
Okay, great. Given the increased popularity of the Medicare Advantage, particularly in rural America, what would you suggest that Congress do to spur this trend along?
Well, certainly one of the things that really should be done is to even the sort of situation when people enter the Medicare program. When you turn 65, the default is fee-for-service Medicare. So that's one of the reasons why you have so many people who then change after a couple of years. Change the default. Another big factor that I think really gets at the rural issue is to change the basis of the bidding. Right now, Medicare is treated as if it was, fee-for-service Medicare is treated as if it was a national program. Of course, it's not really a national program. It's different in every region. It's different in every locality. And yet there's a national standard, there's a national benchmark, and so on. What really ought to happen is that we have full, fair bidding, and in rural areas where the cost conditions are vastly different than in urban areas, that the bids from Medicare Advantage plans are measured against the actual costs of Medicare providing services in those areas.
Okay, thank you. I yield back.
Thank you, Dr. Price. You're recognized.
Thank you, Mr. Chairman, and I thank the panel, and I apologize for being late, and I'm sorry if I repeat myself here. I do want to focus in on the whole issue of competition in a particular area to start with, and that is the area of durable medical equipment. You know, just because something says it's competitive doesn't necessarily mean it's competitive, and so it's important that you drill down and look at actually how programs run. I would suggest, many of us would suggest, is that the competitive bidding system for DME is neither competitive nor is it real bidding. And we have put forward a bipartisan solution to that we call market purchase pricing that we think is superior. But Mr. Steedley, I want to have you reflect a little bit on the competitive bidding system in DME. What are your experiences? For those of us who were in healthcare, I was a physician for over 20 years taking care of patients. We oftentimes see a different example or a different experience than what's relayed here in Washington. So you and your peers are trying to care for folks out there in the real world. What has competitive bidding meant to you all?
Thank you, Mr. Price. You know, Barnes Healthcare Services had the opportunity in round 2 to bid in Atlanta. And surprisingly, we actually won the bid. Yet we declined that bid because the bid came in lower than our bid. And that's an important piece to hear here. 50% of winning bidders in competitive bidding actually bid less than the median price that's accepted. So for us, and it's about a standard of care. There are certain costs that are built into taking care of patients at home. And specifically, if we just talk, if I narrow into the wheelchair example I just used, there's measuring these patients at home. There's working with the physical therapist. There's working with those physicians. It's making sure that these patients are in chairs that are appropriate. And it's important to differentiate, to your point. I'm not talking about just a broken hip or a sore knee that's going to need 2 or 3 weeks sometime or 6 weeks of healing. Some of these patients are terminally ill. Some of these have ALS, muscular dystrophy, quadriplegic, and these folks require specialization when they're chairs. And so for us, when we're looking at our cost structure and the way that the necessity to take care of these patients, the things that they're going to need, the current system for us is not it doesn't bring in enough revenue, quite frankly, to take care of these patients in the way that they deserve.
So what I hear you saying is that there are patients out there that need services, require services, and the system that is being touted here in this town by so many at CMS as being an improvement over it is in fact harming individuals' access to care. Is that an accurate statement?
Well, and specifically, I can tell you, we take calls from patients, quite frankly, for winners in those areas where they've called because they can't get their wheelchairs repaired timely. Some of these patients now we know, and I can supply a couple of these names for you later if you're interested. Have decubitus sores where they were put in inappropriate chairs with the wrong support structure for them. What's going on is at this point, because the cost or the payment system is down so much, that providers are trying to find equipment that's under the cost, and that is not always appropriate for these patients.
See, Mr. Chairman, this is the challenge that we have. It's that you've got folks who are winning bids out here, supposed bids out here, but they don't have the expertise or the ability to carry out the care for those patients in that geographic area. And I want to commend you, Mr. Steedley, for what you're doing. We're going to continue our work on the market pricing program. As I say, it was bipartisan last Congress. We had 180 co-sponsors, 49 Democrats. There's also a push, and I've got a little bit of time left, there's also a push to expand the payment rates for competitive bidding into non-competitive bidding areas right now, and I know that's a concern. In fact, we had a letter that was signed by tens of individuals of the House that I ask unanimous consent to insert in the record to have OIG investigate exactly what the consequence of this would be. And the reason that that's important is that the CMS uses claims data to determine whether or not folks get the kind of coverage or care that they need. And in fact, that's an inaccurate determiner of whether or not that patient is actually receiving the right care. So I'm hopeful that the OIG will give us a report that actually reflects the sincere problems that are out there on the ground. Thank you, Mr. Chairman.
Dr. Price, thank you for bringing this idea forward. Mr. Renacci?
Thank you, Mr. Chairman. I want to thank the witnesses. It's always interesting to come to these hearings and hear some of the concerns and issues. I, too, want to follow up with what Dr. Price talked about. I am actually a member who had a DME company and went through competitive bidding before I came to Congress. I can tell you it was an interesting process because as I thought I was doing a good job, I lost the competitive bid to another party And that's why I heard when we talk about competitiveness, I lost the bid to another party who then turned around and tried to sell me the bid back. And now I know some of that cannot occur anymore with hopefully Mr. Teaberry's bill, which requires securing a security bond. But what I found was that one of the problems with competitive bidding, and again, the name sounds right, and I heard one of my colleagues talk about it being a Republican issue. Hey, Republicans and Democrats, it doesn't matter whether it's a Republican idea or a Democrat idea, it's a bad idea if it's not working. And what I saw in competitive bidding, it was driving good companies out, and at the same time, it was not giving clients the adequate equipment that was needed, and that's Mr. Steele, one of the things I noticed you said. It's interesting, there was a company in Ohio that actually came to me. They had won a bid for canes, a certain number of canes at a certain price, and it was also ruining their reputation because although they provided the certain number of canes at the certain price, it appeared that people, because there wasn't enough other competitive companies out there, were continuing to come to them, and they couldn't provide, they didn't want to provide any more canes at the price because it was not in their best interest. Are you seeing some of those same instances in the business model that you're currently running in?
Yes, sir. And to your point, the binding bid legislation, it actually is not going to go into effect for several more years, so that remains a little problematic. To your point, there's a company in Orlando, Florida that come to visit specifically, and I met with these folks, so I'm talking from my personal experience here. They won every single bid in round 2, all 90 MSAs in every product category in those bids. And all the intention, to what you said a few minutes ago, their intention was to just resell those bids to desperate providers. It's still going on.
Well, see, I wasn't even aware of that, and that is an issue. I mean, I had to live with it, and it became a process where other companies were making money and actually driving the cost down, yes, causing providers to have to sell their product at less than actually a price they could afford to pay. Do you see that also in the current situation where pricing mechanisms are far below cost of actually providing the service?
Yes, sir. That continues. If you look at even from the association perspective, we're seeing a contraction now in the industry. Some of those folks are being bought by larger companies. I can tell you, and just from a financial standpoint, and I think we're all business people in the room, I can tell you those businesses are being bought sometimes for pennies on the dollar. But unfortunately, there are other providers that are going out of business because they did not win the bid. And at some point, because they lost all that business in that area, they're gone. And then the other providers that are left don't have enough left to sustain themselves anymore, so they are now going out of business. What we're seeing, in essence, and it's not competitive bidding is not the right word for this. What you're really seeing is a decimation of this industry. The lowest cost providers out there, the home care communities, are being taken apart slowly at this point. And it's what we don't have. When we talked a little bit about transparency, I said that in my opening statement earlier, we don't have good data from CMS that shows the correlation from the decrease in the Part B spend here and what that translates into on the Part A side. But I know for a fact, I've spoken to patients that are telling me because they can't get service, they are going to the emergency room, or they're being admitted at some point for other problems subsequent to poor equipment or no equipment at all.
Do you, I know you touched on this a little bit, but this practice does have, for me, it has some concerns about patients and the actual care they're getting. I know that when I operated multiple facilities in rural and urban areas prior to coming to Congress, healthcare, nursing home facilities, and I can tell you that it's always more costly many times in those rural settings. Just briefly, what are you seeing with patients? You touched on that, but I want to make sure we hit home on that. What is happening to those patients that aren't getting the proper equipment?
You know, I can tell you, and I just saw this the week before last, I believe. What you're seeing is, you know, people say, well, there's no problem with these patients, no access issues. At some point, what's going on is some of these folks that would ordinarily have got a different piece of equipment now are getting an equipment that's no longer the best for them. For instance, the case I'm referring to, we had, the lady was an elderly lady that was walking around very ambulatory, COPD or CHF, whatever her issues were, but was carrying one of those great big heavy e-tanks around with her. And when I talked to her about that, she has a closet full of them because the provider that won would not give her a smaller, lighter weight portable tank because the cost of that system was more expensive.
Thank you very much. Thank you, Mr. Chairman. I yield back.
Thank you. I'd like to thank today's witnesses for their testimony today. We're going to continue the discussion about competition within hospitals and community hospitals and physician-owned hospitals, as well as looking at, are there better ways to create savings from durable medical equipment bidding, as well as high-quality service to seniors? And before I finish, I can see Mr. McDermott is anxious to submit a document for the record. Mr. McDermott?
Thank you, Mr. Chairman. For the record, I would like to submit a letter from Medicare Rights, which basically is in support of the competitive bidding process, and ask unanimous consent.
Without objection. Going forward and continuing the discussions we had today, we'll also be looking at issues of physician shortages, of disparities in rural health care within Medicare, as well as looking at improved programs on inpatient, outpatient, and other hospital payment systems. So we will be encouraging input from both these witnesses as well as those in the audience today. As a reminder, any member wishing to submit a question for the record will have 14 days to do so. If any members submit questions after the hearing, I'd ask that witnesses respond in writing in a timely manner. With that, the committee is adjourned.
Check 1 2 1 2.
Just want to hear levels too, because down in 1 2 1 2. Check 1 2 1 2 1 2. That's not good.
Check 1 2 1 2.
You notice what? Yeah, when it gets reset, it turns them on. Yeah. This one's dead, by the way.
1 2 1 2. 1 2 1 2. Check 1 2. Check 1 2 1 2.